We are going to cover Chapter 3, Specimen Blood Collection. I'm not going to spend a lot of time going into great detail on the specimen collection because you guys have all had the phlebotomy course already. This is kind of just a quick review of everything that you did learn in that course as far as the blood drawing process goes. So it's going to be nice to hear that, and besides you might see a little bit of it on a test, but nothing in too much detail because our main focus is going to be hematology. But again, kind of a great review. We're going to go over some of the safety, some of the responsibility, the different types of skin punctures, a little bit of blood smears, move into quality control, and even specimen handling and legal issues as we go through this. The first part is safety. You guys are not new to this. You've taken basic lab skills, phlebotomy. We talked about it week 1 in every course that you've had in the MLT program. But it's important to know that we do have to follow the safety regulations that are in place. You have to follow standard precautions, you have to wash your hands regularly, and you have to make sure that sharps are disposed in the proper biohazard container. Of course, those are the hard side red containers. The responsibility of the phlebotomist with this, you are responsible for making sure that you're following the rules that are in place. Okay, nobody else is going to force you to do it and follow you around. You have to make sure. Infection control is very important. As you are drawing blood, and this being a phlebotomist may not be your main role, you may draw blood very infrequently or not at all. But if you do work in a smaller hospital or something like that, where the lab techs do more of the blood drawing, infection control is imperative. So as you're carrying your tray around and going from patient to patient to patient, you have to make sure that you're following those safety rules. You have to be sure you're washing your hands, using hand sanitizer, etc. The procedures that you have to follow include that infection control, the isolation policies that are in place. Okay, so if they have special isolation procedures, you're going to have to go through the training for that. Personal health and hygiene is important. You know, a lot of people don't think of this, but if you wear really strong perfume or cologne and there's somebody in the hospital who's very sensitive to that or is very sick, that can be very offensive and challenging for them to deal with as you're in their room. Always wear gloves. Change gloves between patients, wash your hands because that is the best way to stop the spread of disease, right? All right, the first thing we're going to talk about is the venipuncture. There's a lot of physiological factors that can affect the results, and we're going to get to that a few slides later. But first, we're going to cover the collection equipment. So the needles and holders obviously are very important. They all should have engineering controls, such as a safety device that covers the needle when you're done. You need to use a tourniquet, which is what causes cessation of blood flow so you can get a better flow. Syringes and butterflies are often used, especially in difficult patients. I've seen a lot of people really abuse the use of syringes and butterflies. These butterfly systems are very expensive. The needles are very small in a lot of cases and don't provide as good of a blood sample as a traditional vacutainer collection set. So you really want to be careful with using these and not use them on every patient unless you have small veins or difficult veins. The equipment that we use or the solution that we use to prepare the skin is a 70% alcohol. Okay, you want to allow it to air dry. Certainly don't blow on it. Don't wipe it dry or waft it. Okay, you want to just allow that to air dry. This is a good time to kind of make some small talk with the patient. You heading out for lunch today? Oh, you're fasting? Are you going out for breakfast? I usually kind of ask them something, or if they have a logo on their sweatshirt. You know, someone once was the coach of a local high school football team, and he happened to have a quarter zip shirt on that I could strike up a conversation about. So that's, you don't have to sit there and stare at the patient and wait. Certainly make them comfortable, talk to them. The evacuated tubes have different types of solutions or agents in them that prepare the sample for the department that they're headed to. We can have the anti-glycolytic, which means it stops any usage of glucose within the sample. An anticoagulant will keep it liquid. We can't run a solid clot through a hematology analyzer, right? It may have a clotting activator or some type of a separator gel. I'm not going to read all of these to you. This is something that you should already know, but if you are a little weak in this area, you're going to want to review it, okay? The main specimen that we are going to use in the hematology department is the lavender top tube. There is a very rare situation where we may run a light blue top tube to get a platelet count. We might run a green top tube to get an LAP score. Those are very, very, very few and far between. 99.9% of the specimens run in the hematology department are going to use the lavender or purple top tube. It contains that ethylene diamine tetraacetic acid, and that binds up all of the calcium. It's got 4 calcium binding sites, hence the tetra in it. So it'll bind up 4 molecules of calcium with every molecule of, or sorry, elements of calcium or atoms as one EDTA molecule. So it binds up really fast and it's really powerful. Okay. All right, so venipuncture procedure and vein selection. We have the cephalic vein, which is kind of on the outside of the arm. The median cubital vein, which is more in the middle, that should be your first choice. This is the preferred site for phlebotomy on an adult. If you decide to use a basilic vein, it's going to be a lot more painful. The cephalic vein can be kind of useful, but and not quite as painful, but I think the vein that tends to be the least painful and the most comfortable for the patient is definitely that median cubital vein. The basilic vein is the one that's closest to the body. I always think of, God, how to memorize these, but the basal body temperature is in your body, right? So the middle of your body, and I think the basilic vein is closest to the middle of your body. So that's kind of how I associate that. The hand, okay, you want to use the dorsal surface or the top of the hand, which, should be common sense. You don't want to be poking someone's palm. Feet, sometimes, I've been in situations where there's a patient, a trauma patient, for example, who's in the intensive care unit and they're in a full body cast and all they have is one foot sticking out. So in order to draw off of a foot, and it may sound weird, but if you ever look at your feet, you've got some pretty amazing veins because the skin is so thin, right? Now, the problem with this is people with diabetes or who are prone to thrombosis, if you do something wrong, or even if you don't, there is a possibility of them getting a clot and due to poor circulation, getting a deep vein thrombosis in their leg. Okay? So you have to get doctor's permission to do this. If the doctor says draw from the feet and you do, then your butt is covered. Okay? Don't just go, oh my gosh, you have no veins anywhere, but look at your feet. You want to make sure that, that you're allowed to do that. Never use the inner wrist veins. And with the routine venipuncture procedure, you want to apply standard precautions. Treat everybody as though they have a communicable disease. Okay, so you don't know if people have HIV, hepatitis, or anything like that. So you want to make sure that you assume every patient does. Don't treat them, like a weirdo, but you do want to prevent the, protect yourself as though that may be the case. We need to follow the steps recommended by the Clinical and Laboratory Standards Institute. The very first step, which is the most important, is patient identification. None of this is going to do you or the patient any good if you draw the wrong patient. And true story, I was working in the hospital and we sent the phlebotomist to draw blood cultures ×2. This means you have to draw the right and left arm, 2 bottles from each arm. The phlebotomist proceeded to walk into a room and draw a patient's right arm and left arm, label them, and bring them down to the laboratory. We received a call about a half hour later asking when we were going to come draw the blood cultures ×2 on the patient in room 702. The patient had not been drawn. The patient in room 704 next door had Band-Aids on both arms. The phlebotomist proceeded to walk in the wrong room, draw the wrong patient 2 times for blood cultures ×2. Never looked at the patient's armband. This was a big deal. We had to go up and draw the correct patient, and this was, quite the write-up that this received. So patient identification, can you imagine if this was never caught? A patient doesn't really know a lot of times, especially if they're really sick and under the weather, why somebody's there to draw their blood. They're assuming that you're in the right place. So if you don't ask anything and you just proceed to draw the blood, they're just going to be like, okay, the doctor wants my blood drawn. They may be confused. If they're on a vent in the ICU, they certainly can't talk to you. So you do have to identify them. The order of draw is important for multiple specimens. Make sure that you're drawing the least, potent anticoagulant first, and then to the, lavender and gray tops last. you have to make sure the specimen's labeled, it's handled correctly. If it needs to be on ice, it needs to be on ice. There's special requirements for sodium citrate. Okay, so you have to make sure that blue top is filled to the fill line. If it's not, the results will be inaccurate. The doctor will treat the patient on those inaccurate results. And always label at the patient's bedside before leaving the patient. This would drive me nuts. I would be walking down the hallway in the hospital, and a nurse would come running at me with unlabeled tubes and say, "Oh my gosh, I have to give you these tubes. Hold on, I have to label them." She'd go run behind the nurse's station, flip through a couple of clipboards, grab a label, and label the specimen. I would go back to the lab and write that nurse up because that is totally inappropriate. The nurse should have brought those labels to the patient's bedside before getting that specimen. And you might ask, well, why is the nurse drawing the blood? Well, sometimes patients have lines that come out of like a PICC line or a central venous catheter or something like that, and they draw off those ports. So they will collect the specimens in those cases. But again, they still have to follow these rules as well. Venipuncture in children requires excellent interpersonal skills. This is something I pride myself in. I work at a clinic every other weekend right now. And I have certain kids that come back to me because I'm really good at keeping their mind off of it. I'm really good at anchoring super tight with my thumb so that it pulls their skin so taut they can't feel it. I talk to them the entire time. This is something that takes some skill. It's not something when you go get your first job that you're going to all of a sudden be drawing children like a rock star. It's easier when you have children yourself. Sometimes the parents aren't very helpful. They don't hold the children real well, but I usually get another nurse. We sit with the patient together and talk to the patient at their level. And it usually makes it go pretty quick and pretty easy if you can go fast. A lot of times you're not going to talk a 3-year-old into calming down. You just have to do it. We use smaller gauge needles. Usually butterflies are pretty good in this scenario. Using a vacutainer could collapse their veins, or they're not going to hold still. You lose that vacuum and you're going to be like, oh great, then you have to poke them again. With a butterfly, it gets you a little closer to the patient, so you can anchor yourself a little bit better. Some venipuncture complications, you have to know the definitions of these. Ecchymosis is like little tiny ruptures or hemorrhages under the skin. A hematoma is a bruise. Syncope is passing out. Hemoconcentration occurs from keeping the tourniquet on too long. Okay, so that can affect your blood results. Hemolysis would be from, bursting those red blood cells and usually using too small of a needle and pulling the syringe back too hard. Petechiae is kind of like the ecchymosis, falls in the same category. It's little hemorrhages under the skin, little dots. They could have allergies to something. I don't know of any hospitals or clinics that are using latex anymore, but that could be a problem. Nerve damage from digging. Don't ever dig, okay? If you know you're right next to a vein and you go back out a little bit and go next to it, I don't consider that digging. There's been people who have had some very serious nerve damage issues from phlebotomist digging. You can go on the internet and find some cases of people that have actually lost feeling in an arm from that. Seizures or tremors can occur, and vomiting. I have not had the last two happen to me, thank the Lord. All right, so here's venipuncture in special situations. I always have students say edema. Like, what is that like? Well, you can see in this video to the right here that this is pitting edema. When you go to feel for a vein, your fingerprint's going to stay. These patients are very difficult to draw sometimes. It's difficult to find a vein. You want to try and stay away from edematous sites. If they have one edematous arm and the other one's normal, obviously don't draw the edematous arm. But it can create some issues. Obesity, there's times where you actually have to pretty much bury that needle to get to the vein. Burned, damaged, scarred, or occluded veins, you want to stay away from those. If they have intravenous therapy, you're going to want to have that IV turned off and come back to draw the patient after a period of time. Patients who have undergone a mastectomy, these patients will usually let you know. If you go to draw an arm, they're going to say, you can't draw that arm. I had a mastectomy in that arm. It's like, well, we can't read your mind, but they will be very adamant that you do not touch that arm. Reason being, they've had their lymph nodes removed a lot of times, and it can, if you create some lymphatic issues, it could cause some problems by occluding an area. And if they're in a hospital room, usually there will be a sign on the wall that says, do not draw right side, do not draw left side, etc. So if you have a hard time drawing a blood specimen, you get 2 attempts, okay? If you fail the first time, you get 1 more time. Now, working in the clinic I work in, I'm the only person there on Saturday and Sunday. There is nobody else there. Sometimes patients come from quite a distance, and this doesn't happen very often, but if I don't get them the first 2 times and there is another vein, they may say, can you please draw my hand? Please. And the patient will ask and beg. Never force a patient to be drawn 3 times. Notice this is a CLSI recommendation. You can try 2 times. You can't even force the patient the second time. But after 2 times, that patient's going to start losing a lot of faith in you. And they're going to be like, oh my God, I don't want this person to draw my blood. So usually go get another person so that they can kind of regain confidence in that. But if they do, if you tried both arms and they have a great hand vein, you can say, hey, look at this hand vein. Do you want me to try this? And a lot of times they'll say, yeah, just so they can get it done and get out of there. If the patient refuses, they have a right to refuse. If they come to the clinic or you go to the patient's bedside and they say they don't want their blood drawn, you can ask them to reconsider, say the doctor would like this result because it's going to help them with your further treatment, or they need to know what the results are to help you get better. Those are the things you can say. You cannot give them details on how this lab result will help them determine, don't go into details. Just say this will help the physician treat you, okay? If they still refuse, go and inform the nurse. A lot of times the patient is just confused and angry, okay? A missing patient, so you show up in the room, they're gone, just go let the nurse know. Sometimes they go to therapy, physical therapy, or they're down in the CAT scan lab or something like that, then you just have to ask. We have different types of patients. We may draw newborns or pediatric patients, severely burned adults, extremely obese adults, elderly adults with difficult veins. These are things that are just going to take time to improve. Having worked many, many years, nights and PMs in a hospital where it's just you, I certainly learned quite a bit about dealing with these patients. It's not something coming right out of school that you're going to know how to do. And what I recommend is if you do miss a blood draw on one of these difficult patients, to go get a more experienced phlebotomist to help you. And if you're not too busy, to go with and watch and learn from what they're doing. A lot of times they have tips and tricks on how to deal with the pediatric patients or elderly adults with difficult veins. They may have some things that they do to make the process a little bit easier. So certainly learn from them. They've been around a long time. We can get venous blood, arterial blood, or capillary blood. So arterial blood punctures, you may have learned about briefly in phlebotomy. I would say maybe 50% of hospitals have lab techs drawing arterial blood samples. The other probably have the radiology or the respiratory group drawing the arterial blood samples. There can be effects on different test results. Okay, so if you draw capillary blood, venous blood, and arterial blood, there may be different values. So you may see different reference ranges for those. Collection sites on babies, just a reminder that with kids, you want to draw the sides of the heel. Okay, and it kind of shows here a puncture going this direction. The depth of the puncture depends on the site that you're using. If you're using a little 2-year-old, which is very difficult for a finger stick, let me tell you, because they are not going to hold still and they're going to make a fist with their fingers. You don't want to use the same depth of puncture that you would use for a 45-year-old construction worker who's got calluses on their fingers. Okay, so you want to choose your lancet wisely. You want to avoid sites that are swollen, bruised, infected, or punctured already. So if they've got puncture wounds all over their fingers, choose a different finger. Or if they've got a lot of venipuncture holes and band-aids all over, see if you can find another spot. If the site next to the venipuncture starts to swell, this indicates that blood is flowing into the surrounding tissue. Stop immediately and apply pressure. You don't want to keep going because you can get an even larger hematoma. And some patients, if they get a hematoma, get very worried. You want to avoid patients with dehydration, edema, or poor peripheral circulation. Now, sometimes you can't if they're in the hospital. A lot of patients are in this issue. If there's an order for their blood to be drawn, it needs to be drawn. Some things that can help are warming the site to increase blood flow. Sometimes you have those infant heel warmers that you can add to an adult patient's hand. It's the same thing you can use. I like to fill a clean biohazard bag with really warm water and lay it across their hand. It warms a much bigger area, and it doesn't get the skin as wet and wrinkly as maybe a hot rag would. You always want to wipe away the first drop of blood and use a clean gauze pad, etc. All right, we have different collecting devices. Sterile lancets are usually used. With the capillary tubes we could use for hematocrit. Now, unless you're collecting those very close to the lab, in most cases, we don't collect capillary tubes on patients very much anymore. We usually collect them in a microtainer tube and then take it back to the lab. And if we need to do a microhematocrit, we'll put the blood in the capillary tube in the lab. It's probably 25 years ago working in a small clinic where we did the capillary tubes on the patients to check a hematocrit. But that was at a very small clinic. The micro collection tubes use the same color code as venipuncture tubes, but the one thing I want to point out and have you know is that the lavender tube is drawn first, where when you do venipuncture, usually the lavender tube is drawn last. Reason being is blood clots pretty quick. You want to make sure you get the best flow into that tube. Make sure you wipe the finger before going on to the next tube. You're not going to get that cross-contamination like you would with the venipuncture sets. Blood smear preparation is something that we're going to keep working on. Again, you're not going to be perfect at this right away, which you guys certainly learned. There's two techniques which kind of cracks me up. The wedge up here is kind of what we use. Now, I hold this in my hand, as you guys saw, but here is a cover slip method. I have never in my 25 years of working in medical laboratory science used this cover slip method. But it's on here in case you do come across a site that uses that. You can't tell them that they're crazy because it does exist. But in most cases, 99.9%, you're going to see the slide method that's being shown above, which I don't like because this guy's finger's in the way. And when he goes to make the smear, it's going to smack into his fingers. So it's kind of odd. But one of the few pictures I could find. All right, so why might a specimen be rejected? Well, the test order requisition and the tube identification don't match is one. Okay, so this is one tube and the requisition in the bag are not the same. The tube's not labeled, or the labeling is incorrect, missing too much information. Remember, you need first name, last name, date of birth, date, time of collection, and collector's initials. The specimen could be hemolyzed. It could be collected at the wrong time, which, big deal, right? Well, it is a big deal if the patient is getting any peak or troughs for antibiotic levels. Okay, so sometimes those are timed and they need to be drawn at specific times. It could be in the wrong tube. So if you send an EDTA to the chemistry department for a comprehensive metabolic panel, they're going to say no bueno. The specimen could be clotted. Okay, so if you send a specimen to the hematology department where we need liquid blood, if it's got clots in it, we can't use it. Intravenous fluid. Well, how would you know that? Well, one time we ran a specimen in hematology and the hemoglobin was 1.5. Normal hemoglobin is like 12 to 14. The whole thing was contaminated with IV fluid. It was drawn off of a line and the nurse put the blood in, and once we let it sit, you could see there was like hardly any cells in it and it was all IV fluid. Severely lipemic. Sometimes we don't reject that because recollecting isn't going to reduce the potential. They could have the patient try fasting maybe, but we do have special high-powered centrifuges called ultracentrifuges that can centrifuge out the fat if need be. With the pre-analytical phase of the specimen handling, we want to make sure the specimens are well mixed. You want to mix them at least 8 times. Do not shake the specimens unless the instructions specifically say to shake. There is a new type of tuberculosis test called a TB Gold, and there are some methods of that do require you to shake the specimens, but that's the only one I can think of. You want to transport them upright so that they don't leak out the top. If for some reason the little puncture hole, it could leak out the top. You want to make sure that they're not exposed to extreme light because the bilirubin can be affected. It could be kept on ice. Check the specimen requirements for that. So if it's an ammonia level or if it's blood gases, those need to be kept on ice. If it's cryoglobulins, those need to be kept warm. So if there is a special specimen requirement, you should be made aware of that before doing the testing. And a lot of times it'll say it right on the label. You need to separate the serum and plasma within 2 hours, or those red cells are going to get hungry. They're going to start eating the glucose within the sample. And it's ultimately your job to make sure that the specimen is acceptable before analysis. When it comes to legal issues, this may seem kind of scary, but don't let it be scary. As long as you're doing everything that you're supposed to, you're not going to run into a problem. Breaching patient confidentiality is a big no-no. If you're in the elevator with a coworker, you can't say, oh my God, did you see Sally Sue on 3rd floor? Did you see that, I don't think she's going to make it. Well, okay, so you think that patient on 3rd floor is going to die and you just said her name in the elevator and her child is standing next to you. So you have to keep patient confidentiality very important. Misidentifying a patient, drawing the wrong one, right? Not a good idea. So doing what you're supposed to is going to minimize the risk of legal action. So follow up on all incident reports. If you see a nurse not labeling at the patient bedside, write that up, get your name off of it, okay? If they proceed to bring specimens to the lab, there's no name on it. They label it at the lab, write them up, okay? Get yourself away from the responsibility of it potentially being the wrong patient. Now it lays in the nurse's hands. Make sure you do all your continuing education. Make sure you're certified. Acknowledge the extent of liability coverage. So, that the hospital will usually cover you as an employee unless it is extreme negligence, okay, where you are purposely hurt the patient. Follow the procedures, use professional behavior, obtain proper consent forms when needed, respect the patient's bill of rights. They can say no. Don't do it if they don't want you to. Maintain proper documentation of everything that happens. Those would be the incident reports, and if something does happen, make sure you document that it happened. All right, that completes our chapter on specimen collections. That was a nice little review of pretty much everything you learned in your phlebotomy course.